Okay, I've started the timer and here is your question. Right, so if you have read and understood, considering it's surgical pathology station, kindly tell me after reading the STEM, what are the differential diagnoses that you will consider for this patient?
Okay, ma'am. So my most probable diagnosis is basal cell carcinoma,
Yes,
and differential it can be squamous cell carcinoma, then atopic dermatitis, keratosis,
yes.
then could be melanoma.
How would you confirm your diagnosis?
So we have to do either excisional biopsy,
Yes, and
and we can do even on the same time frozen section or Mohs microsurgery.
yes. What are the, all right, how would you, all right, okay. So if you look at this image, and can you help me describe this? What are you looking at?
Okay, so it looks like a pearly white papular lesion
Yes,
with telangiectasia
yes,
and is everted margin.
yes. What else?
Uh, I don't know.
Considering your differential diagnosis, how would you histologically differentiate basal cell carcinoma with squamous cell carcinoma, please?
Okay, so basal cell carcinoma we have a pearly white lesion,
Yes,
and squamous cell carcinoma it could be a brown or a black lesion.
yes,
Basal cell carcinoma will be a everted or rolled in edge, and squamous cell carcinoma will be inverted and rolled out edge.
yes,
And then basal cell carcinoma is mostly localized,
yes,
and squamous cell carcinoma it is spreaded to the localized, I mean nearby lymph node.
yes. How does the basal cell carcinoma metastasize?
Okay, basal cell carcinoma is mostly locally advanced.
Yes,
It rarely metastasize, but if it's metastasize, it might metastasize to the lymph node
lymph nodes.
by
Yes, very good.
lymphatic way. Yes.
Would you be able to tell me the 5 major steps in metastasis?
Okay,
How
so
does it? Yes,
it can be locally advanced to the nearby tissue. It can be
yes,
hematogenous spread. It can be
yes,
lymphatic spread
yes,
and transcelomic. So I
yes.
don't know what is the fifth one.
Right. Okay. That was the steps I was asking you. All right, you can go through that later. And
Okay, so steps we can say the tumor cell produce vascular endothelial growth factor,
okay.
which is increase and dilate the lymphatic vessel. Then
Yes,
the tumor cell goes to the nearby sentinel lymph node,
yes,
and where it grows into the lymph node.
yes. All right. Okay. Can you tell me histologically, all right, how would you differentiate or what could be the natural history of basal cell carcinoma?
So basal cell carcinoma is slow growing
Yes,
and is a locally advanced
yes,
malignancy, which can be caused by uh, sun exposure. area, mostly
Yes.
on the upper face and
On
maybe on the neck.
sebaceous apocrine origin of it, if you can tell.
Is epithelial origin.
Yes. Is it epithelial or germal?
No, is epithelial origin.
All right. Okay. Can you tell me what are the risk factors which can be avoided or which lead to the formation of basal cell carcinoma?
Okay, so the risk factor, it can be sun exposure, family history,
Yes.
genetics,
Yes.
and maybe smoking,
Yes.
immunocompromised patient.
Patient. Very good. All right. How, considering this patient's stem that you have in, in front of you, the lesion was non-healing and it was there in 0.8 centimeter. How or what management would you suggest to this patient?
Okay, so initially we have to do a excisional biopsy
Yes.
with a safe margin. Then we have to send for histology, or we can even send for micro Mohs surgery on the same time. Then we have to see the types of tumor and margin of the tumor and thickness of the tumor. So if the thickness is deep, then we have to go maybe even for re-excision with a wide excisional margin.
How much margin should be enough, considering you're not sure if it's basal cell carcinoma or squamous cell carcinoma?
Okay, so at least maybe 1 centimeter.
Okay. If it is, all right. So how would you determine if you have to go for re-excision?
We have to determine, depends on the thickness
Yes.
and the margin status by the histology.
And how would you make sure that you prevent the recurrence of deep margins which are involved during the procedure or during the...
We can check maybe most microsurgery or frozen section.
All right. Okay. Can you please tell me, right, after management, what after excision, what other treatment or management can you offer?
After excision or like the treatment options?
If you tell me the treatment options, because
Okay, so maybe we can do a excision, or we can do cryostat surgery by the liquid nitrogen, which is biopsy is not possible. Then we can use Mohs microsurgery, and we can use some local ointment like 5-fluorouracil.
if you can classify the treatment and tell me, like there could be surgical management and there could be non-surgical management, and then there could be
Yes.
tropical and
Okay, yeah,
non-tropical as
surgical
well.
we
So
can do wide excision. We can
yes,
do micro Mohs surgery. We can do cauterization,
yes, yes,
cauterization with cryostat
yes,
and liquid nitrogen.
yes,
And then we can, for topical, we can use like 5-fluorouracil.
yes. Okay, considering if it's basal cell carcinoma, do you think radiotherapy would be effective? Would you suggest radiotherapy?
Yeah, radiotherapy also can be given.
Can be effective. All right. All right. Okay. Right. Just suppose you've excised the lesion of this patient, which was 0.8 centimeter in size, right? And it was because it was on the right sides of the nostril, there was a gap. How would you suggest to this patient to cover this gap? What
So
management or suggestions you can offer?
okay, so we can offer on the same time primary closure by flap skin graft, or maybe we can wait for secondary closure.
What would you suggest for this patient? You have to be specific.
Okay, so I think I will go for primary closure with the flap, skin flap.
Okay, there is a gap, right? And primary closure is not possible. Then what would you suggest? What type
We'll
of
close.
yes?
We'll close with the flap skin graft.
Yes.
Skin graft.
All right. Okay. How long would you wait before you'll offer this management to the patient?
We can do on the same time if frozen section is available. If we find the safety margin, if not available, then we can wait for maybe a week.
Okay. Right. After you have done the graft, you've suggested the repair of the graft to the patient. Patient presents with the non-healing wound at the site of the graft, where graft was placed. So can you tell me what would your next step or mode of action would be?
Okay, ma'am. So it could be for a secondary site infection,
Yes,
wound infection. So we have to send the swab for
yes,
culture and sensitivity.
very good.
And then if the wound is infected, maybe we have to remove the slough.
Yes,
And then we can wait for healing the wound by daily dressing. We can use antibiotic according to the trust protocol, or
yes,
maybe we can communicate with the microbiologist,
yes.
or
What
we
is the
can wait
most,
for
yes,
swab culture sensitivity to
yes.
adjust the antibiotic.
What would be the most common organism that you expect
I think
to?
it's Staphylococcus
Very
aureus.
good. Yes, all right, good. What if the management or antibiotic that you give to the patient, they are not successful and the patient wound is still weeping? What would you suggest? And the report comes back after 2 weeks and it is MRSA positive. Then what management would you offer to the patient?
Okay, ma'am. So in case of MRSA, we have to isolate the patient,
Yes,
and then we have to start. If the patient is not sepsis, if it's possible, we can treat the patient from outpatient department. So we can give oral vancomycin or maybe amoxicillin with clindamycin.
okay.
But if the
How
patient
long?
is like septic and for 2 weeks, and if the patient is septic or maybe a patient need a hospital admission, then we can go for vancomycin injectable, uh, 500 milligram for 2 weeks, or we can go for injection linezolid 600 milligram for 2 weeks. Even if it is still not working, then we can go for clindamycin, either 300 milligram TDS orally, or maybe we can go for IV clindamycin.
Good. Thank you. And all this procedure will be carried out under aseptic conditions because patient has to be isolated. All the
Yes, ma'am.
staff taking care of the patients will take care of special, they have to follow the special requirements
Yes,
so that they won't be carrier, they won't be spreading around to other patients.
yes, ma'am.
Good. Thank you.